Okay, let's get started like good Germans on time. I think you're sort of, there's something German in UKR, isn't it? 100% German. Yes. Welcome everyone to the summer series of 5 new things. We're, I think, right in the middle of it, and probably one of the best talks of those today. Dr. Becker is going to talk to us about stroke, 5 new things in stroke. Dr. Becker, I don't think really needs an introduction. She hailed from Johns Hopkins, where she trained in stroke and neurocritical care. Don't know how we got her here. I don't know if it was Bruce who got you here. I don't know how we were able to keep her. But anyway, we're very happy to have her. She's a full professor in the Department of Neurology, attending at Harvard Medical Center. Here you go. Thank you.
Thanks, Claire. So 5 new things in stroke, and I could really make the talk about these 5 things: Mr. Clean, Escape, IA Extend, Swift Prime, and REVASCAT. And for those of you who don't know stroke well, these are 5 trials of endovascular stroke therapy that have been proven to be beneficial in the last year. But because I don't want to make it all about endovascular therapy, we'll talk about those trials. We'll talk about the role of general anesthesia in endovascular therapy. Talk a little bit about prophylactic antibiotics for prevention of infection in patients with stroke, early mobilization for patients with stroke, and bridging therapy for atrial fibrillation. So, as I said, Mr. Clean, Escape, IA Extend, Swift Prime, and REVASCAT were 5 prospective randomized controlled trials that were mostly stopped early in the last year because of overwhelming efficacy. And I'd like to go through the data for these. As I mentioned, they were all very clearly showed a benefit. And last year when I gave this talk, I told you that endovascular therapy didn't work. And so there's been a pretty huge change. And why is that? The change is really because we're using a different technology for revascularization. We're using a better algorithm for getting to patients. We're choosing the target appropriately, and we're revascularizing in a more timely fashion. So this is a really busy slide, and we're going to spend a bit of time on it. So these are the 5 trials. And let's start with the time window for these trials. So these are all acute ischemic strokes. And you can see that 3 of the 5 trials had a 6-hour time window. REVASCAT had an 8-hour, and Escape a 12-hour time window. So by and large, a 6-hour time window. If you look at the patients that were enrolled in these studies, they were in their mid to late 60s, and the NIH stroke scale score was on median about 17, so moderately severe strokes. And if you look at the imaging for these studies, they were all, for the most part, CT-based studies. Mr. Clean only specified that you needed a CT angiogram to show you that you had a large vessel occlusion, an ICA or an M1 occlusion. The Escape study was also CT-based, and they used a multi-phase CT angiogram. And here the idea was not only to show that you had an occlusion of a large vessel, but that you actually had adequate collateral flow that would potentially allow you to have some benefit from revascularization because the tissue wouldn't be densely ischemic. The REVASCAT study used CTA or MRA again to show the occlusion. The 2 that kind of stand out are IA Extend and Swift Prime. They used a specific algorithm called the RAPID algorithm, and this was developed by the group at Stanford, and it's now proprietary, as I understand. And what it does is essentially looks at this idea of diffusion-perfusion mismatch. So they're looking at cerebral blood volume on CT perfusion studies as kind of a marker of dead tissue, and then the CT perfusion as the tissue at risk. And so they have this specific algorithm that calculates kind of the degree of difference between the dead tissue and the tissue at risk, and they only took patients where they figured that there was a big enough mismatch that they could help people. The other thing that was pretty unique among, I think, these studies is the use of the ASPECT score. We're going to talk about this a little bit later, but the ASPECT score is a CT-based score. ASPECT stands for the Alberta Stroke Program something CT score, and we'll talk about that later, as I mentioned. A couple of other things about these studies. If you look at IA Extend and Swift Prime, These were all studies that were done in patients who got IV TPA within a 4.5-hour time window, followed by revascularization. Mr. Clean, ESCAPE, and REVASCAT treated patients in a pragmatic fashion. If you qualified for IV TPA and got IV TPA, great. If you didn't, you would still potentially be eligible if you came in the time window for therapy. And as you can see, in most of these studies, about 80 to 90% of patients got IV TPA. So by and large, these studies are endovascular treatment on top of IV TPA in an early time window after stroke. The other thing to note here is the time to TPA. If you look at Mr. Clean in particular, the median time to TPA was less than an hour and a half. And most of these studies are less than 2 hours. So patients are getting treated very quickly with IV TPA in these studies. I think the next thing to notice is the time to groin puncture. So on average, about 4.5 hours. So that's pretty quick after stroke onset, with kind of the outer end, and most of these being about 5 hours. So patients are getting to therapy pretty quickly in these studies. And then kind of the million-dollar kind of take-home message from these studies is the efficacy. And all of these studies looked at the ability to return a patient to a modified Rankin scale score of 0, 1, or 2. So these are large vessel occlusions. We realize that the degree of morbidity is going to be a little bit more than would have been if you didn't have a large vessel occlusion. So a score of 0 back to normal, score of 1, some mild symptoms that don't impact your life, a score of 2, maybe your symptoms a little bit impact your life, but you can still do pretty much everything you've always done. And Mr. Clean, you can see that among patients treated with IV TPA alone, for the most part, 19% achieved that good outcome compared to 33% who got endovascular therapy on top of IV TPA, highly statistically significant. ESCAPE, an increase from 29% to 53%. We'll look here at REVASCAT, an increase from 28% to 44%. Kind of the standouts here are IA-Extend and SWIFT Prime. Here you can see that 40% of patients treated with IV TPA alone had a good outcome. And if you follow that with endovascular therapy, it's 71%. And SWIFT Prime, again, 35% up to 60%. So why did these patients do so much better? Well, the patients who just got IV TPA did better in these studies, and the ones who got endovascular therapy on top of it did a whole heck of a lot better. And perhaps it's because they're using this specific algorithm to choose the patients who are most likely to have a good outcome to begin with, and then to benefit from endovascular therapy. These are the data regarding the complications from these studies, and there were no serious complications, no increase in the risk of symptomatic hemorrhage. And one interesting finding is in the ESCAPE study, there was essentially a 50% decrease in mortality, which was statistically significant. So this is the first stroke study ever to show a decrease in mortality with intervention. If you look at number needed to treat, and we're talking about now number needed to treat to return somebody to that really good outcome of a 0, 1, or 2 in the modified Rankin scale score, the numbers range from 3 to 7. 3 with the studies that used the advanced imaging to pick patients who they thought were most likely to benefit, and 7 from the studies that just used a CTA to pick people. So highly effective. And if you look at number needed to treat just to move 1 point better on the modified Rankin scale score, the numbers range from about 2.5 to 4. So this is highly effective therapy when done appropriately. I'm going to walk now through some of the data from these individual studies just to kind of point out some things that I think are important. So Mr. Clean and ESCAPE, again, most people got IV TPA, but not everybody did. And here you can see the benefit of intervention didn't seem to matter whether or not you got IV TPA. If you look at effective stroke severity, here it looks like the people who are benefiting more are the ones with the more severe strokes. So in Mr. Clean, if you had an initial NIH stroke score of at least 20, it seemed to be a little bit more benefit than if you had a milder stroke. And ESCAPE, if you had a score greater than 19, you got a bigger benefit than if you had a milder stroke.
Did that reach statistical significance or just a trend?
No, so here you can see here's the line of unity, so definitely. But between the two, no, no, you're right, there is not statistical significance. And effective age, and I bring this up because most of the studies to date have suggested that elderly patients are particularly at risk for having bad outcomes following endovascular interventions, and here this suggests otherwise. In Mr. Clean, if you look at the patients who are 81 years of age, they clearly benefit from getting endovascular therapy. And an escape, if you look at greater than 88 years of age, not quite statistically significant, but still the point estimate in favor of endovascular therapy. SWIFT prime, if you look again at age, those over the age of 70 seem to benefit. If you look at NIH stroke scale score, again, you see this benefit for patients with more severe strokes. And if you look at REVASCAT, again, you're seeing the benefit in elderly patients and in patients with severe stroke. And REVASCAT was another one where not everybody got IV TPA, but again, you can see the benefit was pretty equivalent between those who did and those who didn't. So how do we select patients for endovascular therapy?
Is there any consensus emerging, or are these studies being reporting on what type of anesthesia they use?
We're going to get to that.
Okay.
Yep. So how do you select these patients? You said that the minimum in all of these studies is you had to have some sort of non-invasive screening study, CT angiogram or MRI angiogram, to show you have an occlusion of the vessel that you want to target with your endovascular therapy. Then there was the extreme to the IEXTEND and SWIFT prime, where they used the diffusion-perfusion mismatch algorithm, and then the ESCAPE study, where they used a multi-phase CTA. But what most of these studies did report on is the aspect score, which is probably an important thing to look at. And again, this is from the Alberta Stroke Program. And what they do is they take standard cuts of the CT scan, and you start with a score of 10. And if you see early ischemic changes in these predefined areas, you start subtracting points. So a completely normal CT scan would give a score of 10. Let's say you see ischemic changes in this territory here, you'd start subtracting points, you get a score of 9. You see more extensive changes, a lower score. And so in these studies, most of them showed that the aspect score was at least 6, but there were a few patients who had lower scores than that. And here you can see the aspect score really predicts outcome as well as response to therapy. So in Mr. Clean, if you had an aspect score of 8 to 10, so nearly a normal CT scan, you were much more likely to have a good outcome after endovascular therapy. And then with ESCAPE, again, you can see, again, that benefit. So having a CT scan that looks relatively normal is important when you enter into an endovascular procedure. And SWIFT prime, again, showing the same thing. And REVASCAT, the same thing. So I think that the take-home from endovascular therapy is that it really works. All 5 of these studies show the same exact thing. It's beneficial and highly beneficial. What they also show is that patients with severe strokes benefit perhaps a little bit more than patients with less severe strokes. Older patients seem to benefit just as much as patients who are younger. Those with higher aspect scores or nearly normal CT scans seem to get more of a benefit. And what I haven't shown you here is that timing is important. If you look at the time to revascularization in these studies, which isn't reported out on all of them to date, it's just like IV TPA. The sooner you get the vessel open, the better off the patient is. And the other thing I said is some of those studies went out to 8 or 12 hours, but if you looked at the time to grain puncture, they were still in the same ballpark as the studies that only had a 6-hour time window.
Kyra, the SWIFT prime study, those 2 studies that use the advanced imaging techniques, would it be fair to say that some of the people that would have been treated in the other studies would not have been treated in the SWIFT prime study because they would have been excluded by this more rigorous criteria?
I think that's exactly right. They had to screen lots more patients just to enroll the few that they did in those studies. So much more selective. And we've talked about how we should approach this. And I think the bottom line is in the Mr. Clean study, which used nothing other than a CTA, they still showed a benefit. So it's unclear where we should be on that spectrum. And we've had some discussions and they'll be ongoing. But I think at minimum, you should have an aspect score of at least 6. And if you have a score that's less than that, we probably shouldn't be treating you. And then diffusion perfusion, I think we're all kind of still noodling on what to do about that.
It almost seems that if you were unlucky enough to come into the hospital for the SWIFT prime study, you might have been denied the potential advantage
That's
of
exactly
clot
right.
extraction.
Yeah, that's exactly right.
I don't think any of these trials prove that the non-mismatched people don't benefit from.
That's the next trial.
Well, that's right, because they only include the mismatched people.
Right.
So, right. and those two that used that kind of imaging. Right. So now to the question of anesthesia for endovascular therapy. So this is an older paper now, and I've shown you these data several times before. And this was kind of a pooled analysis of endovascular procedures and outcomes among a number of different academic medical centers. And they showed that if you look at all of the things that usually predict outcome from stroke, that general anesthesia, when controlling for all of those other things, was still associated with a twofold increase in bad outcome. Since that time, there's been a couple of other publications. These are data from the SOLITAIRE Registry. And so what I haven't really kind of stated probably explicitly enough about the new trials is that the way we do the endovascular therapy, the devices have evolved since the other studies. And the SOLITAIRE device is essentially a stent retriever. You put it up in the vessel, open up the stent, kind of plaster the clot to the walls of the vessel. You leave it there for a minute or two, and then you pull it out. And so it's a very different device. Swift Prime and IA Extend only used SOLITAIRE. In the other studies, most of the patients got SOLITAIRE, 90% or so got SOLITAIRE devices. So in the SOLITAIRE Registry, this wasn't a prospective randomized controlled trial, but really just a registry. They showed as well that the use of general anesthesia was associated with a twofold outcome, or twofold increase in the risk of a bad outcome, and a threefold increase in mortality when controlled for other things. Looking at the use of general anesthesia in the IMSIII study, and this was the Interventional Management of Stroke study, and this was an NINS-funded study. Patients get IV TPA, followed by endovascular therapy or not. And that study showed no benefit. Very few of those patients had the SOLITAIRE retriever used, and the time to therapy was a little bit later. So this was kind of the earlier generation of failed trials. But what they did show here is that anesthesia was used for a variety of different reasons. One, because it was medically indicated, presumptively that patients weren't protecting their airway or something else was going on, or that it was just the practice in your institution that you use general anesthesia, or the practice in your institution that you use conscious sedation or local anesthesia. And what you can see is that based on indication and use of general anesthesia, the chance of a good outcome is very different. So those who got conscious sedation did the best. And as you might guess, those who had anesthesia for a medically indicated reason did the worst. But those who got general anesthesia just because it was the practice in your institution did worse than those who got conscious sedation. And here you can see this kind of put into numbers. So about a 50% decrease in the chance of a good outcome and a fourfold increase in the chance of death when anesthesia was medically indicated. And while not statistically significant, you can see trends, again, for bad outcome in routine intubation in the IMSIII study. In the 5 studies that we've just talked about, if you look at the use of general anesthesia, it ranged from about 10% to about 30-some%. So most patients did not get general anesthesia in these studies, which might be another reason that they were positive. And if you look at Mr. Clean, which was the first of the reported studies, and you look at the use of general anesthesia versus local anesthesia, you can see the difference in good outcome here, which was statistically significant, even when you control for baseline stroke severity and patient age and those other things that we know predict outcome. So just to kind of talk through why use of general anesthesia might be bad. So this is a CT perfusion study, and again, this is the kind of study that was used in the studies that used advanced imaging for endovascular therapy. This is an elderly woman who came in with a sudden onset of right hemiparesis and aphasia. Down here you can see the cerebral blood flow map, and in the left hemisphere you see a decrease in cerebral blood flow. You see an increase in mean transit time, but you really don't see a change in the cerebral blood volume. So this would be a person who's considered to have tissue at risk. It's not infarcted yet, which would be shown by a change in the cerebral blood volume, but there is a decrease in blood flow. And this was the angiogram that went with that patient. You can see the left M1 occlusion. She goes to endovascular therapy, and this was done under general anesthesia. And you can see at the start of the case, her systolic blood pressure was 150. A few minutes later, it was down just above 50. And if you look at the ventilatory status of this patient, she was hyperventilated for a period of time. I think this is not uncommon for people who get intubated during procedures. Their blood pressure drops. They automatically get started on fairly robust ventilator settings, and that can be a problem. So this is the autoregulatory curve that we talked about for cerebral blood flow, and that cerebral blood flow remains constant over a wide range of cerebral perfusion pressures, but that actually works in non-ischemic brain. When you have ischemic brain, blood flow becomes passively dependent on blood pressure, so dropping blood pressure is not a very good thing. And then the response of blood flow to changes in the partial pressure of carbon dioxide in the blood is pretty robust. And small changes in the arterial content of carbon dioxide change cerebral blood flow pretty dramatically. And so you can see if you had a normal PaCO2, your cerebral blood flow would be normal around 50, but just dropping it into the high 20s can drop your cerebral blood flow quite significantly. So you've taken somebody who's not yet infarcted their brain, they have low blood flow, you intubate them, you drop their blood pressure, hyperventilate them, and you drop their cerebral blood flow. It seems obvious that they're going to actually have a worse outcome. What hasn't been addressed in any of these studies is whether the choice of anesthetic, if you're using propofol or some other anesthetic, is actually contributing to outcome. So I would say that the general consensus, and we'll go through this in a little more formal fashion in a moment, is that we shouldn't use general anesthesia for these interventions if we can avoid it. And I give a shout out to Deepak Sharma, who's in neuroanesthesia here, who's really worked hard at Harborview to change our institutional practice. And we have gone from all general anesthesia to very selected cases only for general anesthesia when we do these procedures.
Sorry, one comment on the hypocarbia or the low end-tidal CM2. It might have also been because of such poor lung perfusion with profound hypertension. So their arterial peak CM2 might have actually been much higher than their end-tidal because of poor lung.
Yeah, so the point was just made that what I showed was end-tidal CO2s, which might not actually reflect the PaCO2. So that's a fair assessment. Just to show you how these procedures can go well, this is a patient who came in with a right M1 occlusion, who you can see the M1 occlusion here on the intraarterial angiogram, and following revascularization with what our interventional neuroradiologists call this Solumbra protocol. They take the solitaire device, open up the vessel, then take the penumbra device and suck it out through. So they use two different devices to get it out, but you can see this nice, beautiful result. And despite having an M1 occlusion, this is the only infarct they had after a pretty rapid revascularization, and they walked out of the hospital just a couple days later. So these procedures really can work and work very well. So as you might expect with all of these positive trials, the American Heart Association, American Stroke Association has revised their guidelines, and I'm going to walk you through some of these revisions. One thing that hasn't changed is if you're eligible for IV TPA, you should get IV TPA, and you should get it as quickly as possible. You should get endovascular therapy with a stent triever. They made that very specific because we don't have positive data from trials that really didn't use mostly or exclusively stent trievers. If you're in a good starting condition before your stroke, if you've gotten TPA, if you have an occlusion of the ICA or M1, because that's what most of these studies address. So if we're talking about more distal occlusions, M2 or ACA occlusions, it's unclear, or PCA occlusions. You have to be at least 18 years of age, an NIH stroke score of at least 6, an aspect score of at least 6, and the groin puncture should happen within 6 hours of stroke onset. Again, reduced time from symptom onset to reperfusion is associated with better outcomes, and a TICI grade 2B or 3 should be achieved as soon as possible and within 6 hours of symptom onset. So the TICI grade, so it's the treatment and cerebral ischemia scale, and you can see a grade 2B or 3 means you've completely opened up the vessel, or you've opened up at least half of the territory of that vessel. A couple of other things from the guidelines is that, you know, starting beyond 6 hours, even though some of these trials had a longer time window, is kind of uncharted territory. And even though the trials mostly looked at patients who had been treated with TPA, if the patient had some contraindication to TPA, they should still be considered for endovascular therapy, but with certainly less evidence to support that. Reasonable to favor conscious sedation over general anesthesia. The benefits of additional imaging beyond CT, CTA, or MRA are unknown at this point, so using the more highly selective imaging selection protocols is of unclear benefits. And then finally, as makes sense, regional systems of care now need to be developed so we can get patients to centers that can do endovascular therapy very quickly. So endovascular therapy is a big deal. It's what everybody in the stroke community is talking about. And when you think about it, in 1996 is when IV TPA was shown to improve outcome in stroke. So we waited 20 years for another therapy. So now we have two. Hopefully it won't be another 20 years till the third therapy.
So can this be done after cardiac surgery, for example?
Yes.
For frozen embolus?
Yes. Again, it would be a little bit uncharted because those patients wouldn't be getting IV TPA, but I think that we would all do that. So switching gears now to a different topic, post-stroke infection. And I've talked a lot about post-stroke infection. We know that when you control for everything else, stroke severity, intubation, patient age, and other comorbidities, it's very clear that if you develop an infection in the post-stroke period, you have a worse outcome. And so then the big question is, if we can prevent post-stroke infection, can we prevent that worse outcome? And so should we use prophylactic antibiotics? So I'm going to walk you through some of the studies that have been done. This study is again an old study done 10 years ago by Untitled Chapter in Barcelona. And they took patients with ischemic or hemorrhagic stroke who could be enrolled within 24 hours of stroke onset to treatment with levofloxacin or placebo for 3 days, and then followed them to 90 days to look at the outcome. And what they found was A, treating with levofloxacin didn't prevent infection, and B, the patients who got levofloxacin actually had a worse outcome from their stroke than those who didn't get levofloxacin. A group in Berlin said, well, you know, there were some problems with that study. They treated all comers. We want to only treat patients with more severe strokes who are more prone to get infection, and we're going to treat them with more robust antibiotics. So severe MCA strokes, and we're going to give moxifloxacin for 5 days versus placebo. And what they found here in the intent to treat analysis was no benefit in preventing infection. If you look at the per protocol analysis, perhaps there was a decrease in the risk of infection. But importantly, there was no change in outcome. If you look at survival between antibiotic and non-antibiotic treated patients, no difference. And here you can see again the statistically significant increase in mortality among patients who had infection versus those who didn't. Next study to come along was another German study. And now instead of using a fluoroquinolone, they're using a beta-lactam antibiotic, mezlocillin. They also took patients who had very severe strokes that were bedridden, started within 24 hours of stroke onset, and treated for 4 days. And what they found in this study was a decrease in the time to first infection and the number of infections. And if you look at 3-month outcome, you can see that more of the patients treated with mezlocillin had a modified Rankin scale score of 3 or 4 than those not treated with mezlocillin. So a caveat about this, there's nobody with a modified Rankin scale score of 0, 1, or 2. So these were really severe strokes, and they all had bad outcomes. So it's hard to know exactly what to say about that, but at least there was an apparent benefit here. And if you do a meta-analysis of these studies, you can see that there probably is a benefit in preventing infection, but no difference on mortality and no real assessment of morbidity in these studies. But I think the thing to point out is that these were all single-center studies, and they were very small studies. So hard to know what to make of them. Then comes along the PASS study, the prophylactic antibiotic stroke study, and this was a study that was done in the Netherlands and just published a few months ago. So this was a prospective, multi-center, randomized, open-label study. It included patients with ischemic or hemorrhagic stroke and treated them within 24 hours of stroke onset with ceftriaxone or placebo, or actually usual care, not placebo. And they ceftriaxone for 4 days. And the primary outcome was a modified Rankin scale score at 3 months. The secondary outcomes are the ones you might expect: mortality, infection, and other important things. So busy slide, but to show you how big this study was, 1,200 patients in each group. So the other study, the meta-analysis of the other studies only came to about 1/3 of this number. So this is a huge, hugely large study, and I think adds a lot to our knowledge. And here you can see that the use of ceftriaxone for 4 days after stroke compared to usual care decreases the risk of infection, pretty much driven by a decrease in urinary tract infections. There was a trend toward decrease in pneumonia, but not statistically significant. The other thing I think that is important to point out is these diagnoses of infection were made by the clinical team. And if you take an expert panel who's removed from clinical care and say, do you think this patient had an infection? You can see the data down here. And essentially, they thought only about a third of the patients, or a half of the patients that were clinically diagnosed with infection actually had an infection. But the results were still the same, that the ceftriaxone decreased the risk of urinary tract infection with a trend toward a decrease in the risk of pneumonia. A couple caveats about this study. Most of the patients had very mild stroke, and IH stroke score of 5. So hence, if you go with the expert panel, and you look at all infections, only 7% had an infection. That's way lower than most studies report. Most studies are reporting about 20% of patients with stroke who develop post-stroke infection. So the mild strokes might have accounted for that, and probably colors the outcome of this study in general. Here you see the 3-month modified Rankin scale scores of patients treated with ceftriaxone versus not, and you can see that virtually they're identical. There's no difference. This study did confirm, though, the negative impact of having an infection, and the odds ratio for an unfavorable outcome, and that's the modified Rankin scale score of 3 or higher, was 10 for pneumonia and 2 for UTI. And like every other study, it shows that the detrimental effects of pneumonia, or I should say pneumonia has far more detrimental effects than UTI. So pneumonia is a more serious infection, probably there's a lot more inflammation, and it's associated with a much worse outcome. If you look at subgroup analyses to see if there were specific groups of patients who might have benefited, you really don't see much here. And so I just want to stop and just talk about antibiotics for a moment. So the study done in Barcelona with levofloxacin showed that levofloxacin actually worsened stroke outcome. The study with moxifloxacin showed potentially a decrease in the risk of infections with no benefit in outcome. Fluoroquinolones actually have known neurotoxic properties. They can make people delirious, they can make people seize. And so it's maybe not such a leap to think that maybe the antibiotic is having some off-target effects, and the lack of benefit could be related to that. On the other hand, beta-lactam antibiotics like mezlocillin in the German study that did show a benefit, and ceftriaxone in the big Dutch study that didn't show a benefit, actually have been shown to have neuroprotective properties. And ceftriaxone in particular has, in animal models of stroke, shown to improve outcome, and has been used as a potential treatment in ALS, for instance, because it can actually increase glutamate reuptake. So I think we need to kind of maybe think more simply, less simply than just using an antibiotic, but maybe choosing antibiotics more wisely. And interestingly enough, in the PASS study, in a post-hoc analysis, they found that among patients who got TPA, ceftriaxone was associated with a better outcome than usual care. So something about the ceftriaxone might have improved outcome in patients who got reperfusion therapy. Interesting to think about. So this is a paper we just published using an animal model of stroke. And in this study, we took rats and we gave them a stroke. A day later, we started antibiotics. We started either a beta-lactam antibiotic, ceftiofur, a fluoroquinolone antibiotic, and rofloxacin, or a placebo. We treated them for a week, and then we sacrificed them a month later. And this is a very busy slide to show you some results from behavioral outcomes. So in our hands, what we found is one of the most sensitive tests in the strain of rats that we use is their performance on the rotarod. So rats are trained to run on a rotarod that's increasing in velocity. And you see how long they can stay on there. And you train them up before you ever do anything to them. Then you give them the stroke and see how long it takes them to get back to their pre-stroke performance. And so this is their pre-stroke performance up here at weeks 1, 2, 3, and 4 after stroke. And here you can see, if you look among the animals, and these are individual animal data, that actually return to baseline performance, you see a lot more of the gray diamonds, which are the ceftiofur-treated animals. And down here in the animals that are doing poorly, you see a lot more of the open boxes, which are the enrofloxacin-treated animals. This was statistically significant. So just these antibiotics changed the outcome in an animal model of stroke with no infection involved. We currently have a bunch of data we're analyzing, looking at kind of the addition of infection to this model, where animals were given pneumonia with either a gram-positive or gram-negative bacteria, to see how this all pans out.
Here, can I ask a couple of questions? So I haven't kept up with this literature, but our friend Uli Dernagel for years swore that virtually every rodent that received a stroke wound up being basically septicemic from from bacteria, and that this was a huge contributor to stroke morbidity. Is that gone now?
You know, they're certainly in their hands, or in their mouse model, that happens a lot, but they've also shown in their lab that it's very strain specific. Not all mice are equally susceptible. And it's the same way with rats. The immune systems are very different among these animals, and I think that this is just not the case for most models. What is very interesting, and I'm glad you brought up that name, is so certainly these antibiotics could have a direct effect on the brain to change outcome. But the other really hot area in stroke right now is the contribution of the gut microbiome to outcome and your immune response. And so it's probably these antibiotics are affecting the gut microbiome in very different ways and might be playing a role in that regard. So there's been some really cool stuff going on with fecal transplants and showing beneficial outcomes following stroke. If, for instance, you take the feces of a young animal and transplant them into an old animal, it actually improves outcomes. So, fascinating stuff.
You showed us some data which clearly indicates that pneumonia is a bad thing to happen. On the other hand, the huge study, Dutch, I guess, or wherever it was, indicated that the treatment with an antibiotic never reached statistical significance for pneumonia.
That's right.
Which means it's not statistically significant.
Well, so the antibiotic didn't prevent pneumonia, but pneumonia still was associated with a bad outcome.
Right, but getting back to the question of whether to use an antibiotic or not use an antibiotic.
I think there's no data to support it right now.
All right.
Yeah. So again, changing gears to stroke rehabilitation. This was a study, again, an older study of constraint-induced movement therapy, which I think is still the only study, unless I've missed something, to show a benefit in the rehab world. And this is kind of the gold standard. And constraint-induced movement therapy is, as you see pictured here, patients have their good arm restrained or omitted, so they're forced to use their affected limb. And in the JAMA study I just showed you, they showed a benefit to use of the affected limb following therapy with restraint of the good limb. And that really kind of took off, and everybody started then doing modifications of constraint movement therapy, not like it was done in this study, but their own versions of it. And there was a paper just this year in Lancet, and part of the reason I wanted to mention this, stating that constraint movement therapy seems to work, but all of the modification studies have been very small, very underpowered with methodologic issues. And I think they also kind of end by saying we need more studies because all of these additional studies will, I think, cloud the picture more than they help. And so we maybe need to prove that CIMT really does work. And I wanted to throw two studies in here that I think are fascinating in that regard. So this, again, is an older study by Andrew Dromerick, and this was the Becker study, very early constraint-induced movement therapy. Most of these studies have started 3, 6, 8, 9 months after stroke. Andrew said he wanted to start early, and here you can see they started within 10 days after stroke onset. And they did graded therapy, low dose, so 6 hours a day wearing the mitten, or high dose, where 90% of your waking hours you're wearing the mitten, or usual therapy. And they got 2 weeks of therapy, again, starting 10 days after stroke onset. And what you can see here on these different measures of arm and hand function is that the patients who got the high dose therapy actually had worse outcome. And this kind of set the rehab world back a little bit. And there's our animal models to show this as well, that if you do really aggressive restraint therapy in rodents following stroke, right after their stroke, they have worse outcomes. And their stroke size increases. So when is the right time to do constraint-induced movement therapy? I think that remains an open question, but certainly probably not very early on. And then this more recent publication, I think it was really fascinating. They decided to send patients home and do constraint-induced movement therapy, and they found no benefit at all. So I hate to be kind of a naysayer, but I think that there's still a lot of questions in my mind about the utility of this therapy, especially because there's really just this one gold standard therapy and then or study and then all these other little things in the background. The real reason I wanted to talk about rehab stuff was because of the AVERT trial. And this was, again, another study that was just published this year. And they looked at very early mobilization after stroke with the idea that getting patients out of the bed, getting them moving would lead to a better outcome, decrease complications of lying in bed. And so the goal was to get them moving within 24 hours or kind of usual care. And here you can see that the difference between the two groups are pretty significant. So in the very early mobilization groups, patients were out of bed within 18 hours after their stroke versus 22 in the usual care, so they still got out of bed pretty early. But if you look at the frequency of mobilizations per person, 6 versus 3, the daily minutes of mobilization, 31 versus 10, and the total amounts of mobilization, this is over the first 2 weeks, you can see again a huge difference. So the patients who got very early mobilization got a lot more time out of bed and got out of bed earlier than the patients in usual care. And here in these grotto bars, you can see there was essentially no difference in outcome among these patients who got mobilized early and those who didn't. And if you look at the likelihood of a favorable outcome, those with early mobilization actually had a decrease in the risk of a good outcome, a decreased chance. So early mobilization was associated with worse outcome than not. So let's talk about why that might be. So these are the subgroup analyses. And it was really, I think, probably driven by patients with severe stroke. And severe in the study was NIH stroke scale score greater than 16. Here you can see the point estimate of harm is most significant for that group. I shouldn't say most prominent, not significant for that group. So probably contributing to the worse outcome. And patients with hemorrhage also seem to do worse, probably because they also had more severe strokes. And again, patients who got moved very early, very early actually did fine, but there weren't many of those patients. Early versus later did worse. So I think I would say that for patients with really severe strokes, you should let them rest in bed for a day before you get them moving, based on this study. And there weren't any falls or anything like that. I think probably more related to getting out of bed and your blood pressure falling when you're trying to perfuse your brain. So people probably know this deception pass bridge, and we'll talk a little bit about bridging therapy. And I chose this topic because I think it's always something we struggle with. What do we do with our patients who have AFib and they need to have a procedure? And this study was done to answer the question, is foregoing anticoagulation in the perioperative period non-inferior to bridging with dalteparin in patients with AFib? And they included patients who had AFib, either paroxysmal or chronic, were on warfarin and had the usual warfarin goal and had been anticoagulated with warfarin appropriately for the 3 months prior to entering into this study. And they had to have a CHADS-2 VASC score, or CHADS-2 score of at least 1. So they had to have one additional risk factor here. And so this was the study design. So patients had a planned procedure. 5 days before that procedure, they stopped their warfarin. 3 days before the procedure, they either get dalteparin or placebo. They get their procedure. And for patients who had low-risk procedures, 1 day later, they get restarted on their warfarin, and they get restarted on dalteparin or placebo. For patients with higher risk procedures, they start their warfarin or their dalteparin or placebo 2 to 3 days later. So there's about a 6 to 8 day, 9 day range of being off warfarin in this study. And here are the characteristics of the patients in this study, what you might expect older patients with AFib to have. But to point out their CHADS-2 score, most of the patients had a CHADS-2 score of 2, with kind of an equal distribution between the 1s and 3s. They weren't supposed to have anybody with a 0, but it looks like one patient snuck in each of the arms. So just to remind everybody, the CHADS-2 score looks at risks and comorbidities that would increase your risk of stroke with atrial fibrillation. And a CHADS-2 score of 0 is considered very low risk, and patients only need to be treated with aspirin. When you get a score of 1, aspirin or anticoagulation, score of 2 means you should be anticoagulated. And here you can see the annual risk based on your CHADS-2 score. So again, most of the patients in this study get in with a CHADS-2 score of 2, so their annual risk is 4%, and the recommendations are they should be anticoagulated. A couple of other things. Very few of these patients actually had stroke, about 10% prior to being enrolled in the study. And about a third of them were on aspirin in addition to their warfarin. If you look at the number of days off warfarin before the procedure, it was 5 as planned. And if you look at the number of days after the procedure off warfarin, it was about 1.5 as planned. And if you look at the interruption of the aspirin treatment, again, about a third of the patients were on aspirin in addition to their warfarin, and most of them remained on aspirin throughout this time. The aspirin wasn't stopped. And here's the outcome. There were very few strokes, only 5 total, 2 versus 3. So bridging is no better, or I should say that not bridging is not inferior to bridging. So if you look at the patients who actually had stroke in this study, their mean CHADS-2 score was 2.6. The median date of thromboembolism after the procedure was 19. So I found this very fascinating. I generally think if you stop someone's warfarin, they're getting a procedure. If they're going to have their stroke, they're going to have it around the time of the procedure or the day or 2 after. But this is showing us that 19 days after the procedure is when the strokes happen. And so I think it's interesting to think about. So it's reflecting what happened a few weeks ago when you have your stroke, not what's going on now. So these patients likely had very adequate INRs at 19 days after the procedures. So just an interesting aside when you're thinking about causation for patients who come in with a stroke on warfarin and their INR is normal. What was it 2 or 3 weeks ago? I shouldn't say normal, but in range. The other thing about this study is that use of bridging was associated with a lot more bleeding complications. So I would say that for most patients, bridging is really a bridge to nowhere. It doesn't really seem to be of benefit. Having said that, I think we all see those patients who come in and have been stopped for their tooth extraction or their colonoscopy and have a stroke. And I just don't know how to reconcile those patients we see all the time in the data from a large prospective randomized controlled trial.
Called statistics.
Yeah. So to summarize, I think that endovascular therapy should be offered to patients with IC and MC occlusions. Everybody who's eligible for IVTPA should get IVTPA. Therapy should be delivered as quickly as possible. And we should avoid general anesthesia at all costs when we do these endovascular procedures. Infection is associated with worse stroke outcome. The current data don't support the use of prophylactic antibiotics. My own personal bias with very little data to back this up at present is that maybe we should use non-fluoroquinolone antibiotics if that is an option. Aggressive early mobilization might be associated with worse outcome, especially in patients with severe stroke. And then finally, bridging therapy doesn't seem to be of benefit for the average patient with AFib. You can forego bridging without an increase in the risk of stroke. So we have plenty of time for questions, and I'll be happy to take them. David?
It went by a little fast and I wasn't paying attention probably. How many of the bridging trial patients had actually had a stroke?
10%.
10%. So it's not necessarily a great look at the patients that we're weighing in on this.
Exactly. But those were not the patients who actually tended to have strokes in the trial of the 5 patients who did. Right? Yeah.
Kyra, so the anesthesia thing is really fascinating, and I'm throwing this out partly to see what reaction there might be in the audience. And I don't know if John Weinstein is in the audience.
He's in Australia, I believe.
He's in Australia, so he won't be able to say anything. So general anesthesia has been around as an interesting, potentially complicating factor for the intrinsic sensitivity of brain tissue to a period of ischemia. So it's just been floating around. Some people saying actually it might be protective, other people saying it's actually damaging. So we did a study which we hope will soon be published on ischemic preconditioning in white matter, and the control arm of that study was a bunch of animals that got a sham preconditioning experience. They were put under general anesthesia, had their skin open, but no procedure to affect cerebral blood flow, essentially controlled them. And then 3 days later, we investigated their sensitivity to a very standardized ischemic period. And the white matter that was subjected to this was almost twice as badly damaged as a true control group, matched in every other way, species, age, sex, etc. So it left me speechless and essentially stunned that 3 days after a brief period of anesthesia, with the tissue outside the body and under extraordinary levels of experimental control, that the outcome to this standard ischemic insult was dramatically worse. Any comments? Obviously, this has to be verified, but the data we have reaches statistical significance, and I'm pretty sure it's true.
And the anesthetic was isoflurane? I think that's what we usually use on rodents. Yeah.
I'm going to say yes, but I'm not absolutely certain.
You know, I might see pratik. Do you have any?
Of the drugs, at least that we talk about in clinical use with neurotoxicity in the OR, sevoflurane mostly is the one that we indicate as the bad actor, both for associations with neurodevelopmental outcomes with kids who've been exposed to multiple anesthetics as children. So if it's ISO, that actually surprises me. I was expecting you were going to say SIBO or maybe propofol.
Yeah, well, unfortunately, I can't tell you what it is. But what I'm driving at is my expectation is that this is an experience which heightens intrinsic tissue sensitivity to ischemia, and then probably that disappears over a period of time. When I go to the anesthesia literature, I find essentially nothing helpful. Nothing. Imagine this. If you're going in and you're being put to sleep, wouldn't you like to know that if you have a stroke in the next 72 hours at least, maybe a week, you're going to do substantially worse than if you'd had that same event without the anesthesia. You'd want to know which anesthesia is the least likely to do that to me. And this is not an uncommon event. In fact, right now somebody's asleep in our operating rooms and is potentially at risk for something.
Yeah.
The other challenge that isn't really well sussed out in the stroke literature about GA versus local for acute stroke endovascular therapy is the minute-to-minute blood pressure data. So with the induction of general anesthesia, almost invariably you'll have hypotension associated with almost all of the anesthetic agents, and especially the doses of induction agents that we use. So if one were to actually randomize patients to GA versus MAC or equivalent stroke types, part of that protocolization should be really extreme adherence to blood pressure around induction. And as opposed to having an A line afterwards, as we do at Harborview now, mostly slating off of the FEM line, actually placing on our own A line and titrating carefully the drugs that we use for induction. If you wipe out the blood pressure effect, some of us at least think that we may wipe out the GA effect.
So I would dispute that by saying the patients, or rather the animal patients that undergo ischemia, are protected 3 days later. They're not damaged. They're better off having a period of ischemia, you know, not a damaging period, but a brief period, like a severe period of hypotension. They do much better at 3 days. And again, it's probably an effect dependent on interferon gamma and some other immunologic factors, which disappears after a few weeks. So this is, I literally couldn't believe my eyes and went back and had those experiments repeated.
an interesting area. So
I knew
Sandeep,
you were using ISO.
I'm sure you were using this one. Yeah. That's my guess.
I'm the only person in the room who's not sure.
Sandeep asks if I can comment studies that might be in the pipeline for blood pressure control after stroke and intraparenchymal hemorrhage after Interact. So Adnan Qureshi's ATTACH study is still ongoing as far as I know. That was it's a study looking at aggressive control of blood pressure after intracerebral hemorrhage using nicardipine within a 3 or 4 hour time window. And then for blood pressure control after ischemic stroke, I know Philip Bath has been looking at and has some interesting data and is going to be starting a large phase 3 trial using nitroglycerin, or as they call it in the UK, something different. GNT instead of NTG. It's the same letters, but in a different order. But they've shown that patients who get nitroglycerin on the way to the hospital actually seem to have a better outcome, especially if they get TPA. And so there's something maybe about a nitric oxide donor there that might be a benefit. I think his initial thought was maybe it was related to decreasing the blood pressure acutely. Don't know if that's going to pan out. But I also know that Jeff Saver, kind of in the wake of the FastMag study, now that they have this kind of process in place to do these large out-of-hospital trials, have been interested in the idea of using something like nitroglycerin to treat blood pressure on the way to the hospital as well. So I think those are kind of the studies I know about. There's probably more that I don't know about.
I have a feeling a year ago or so that endovascular therapy was going to go away, and it just seems like it's such a dizzying about face now that to say that it's the standard of care. And I've seen these retrievers, these stent retrievers. They look like they would do a worse job than the penumbra or something else to grab little clots going off. What do you think is about these stent retrievers that are so much better?
I think that they open up the blood vessel immediately. So it used to be they'd be there sucking, trying to pull the clot out. These, you open it up, boom, it's open. They get the catheter in place, they open it up, and blood flow is restored. So it's essentially instantaneous. So I think that's a big plus.
Except that you said it works for up to 6 hours. I mean, even
Well, so it probably doesn't work for everybody up to 6 hours, but for, because advanced imaging wasn't done for all of these studies, I suspect there's a subgroup that doesn't work up to 6 hours. And they might be screened out by the aspect score as well. So if you already have, a pretty large area on your CT scan that looks dark, then you're probably not going to benefit.
And,
So you've got to have a little bit of perfusion somehow keeping things alive.
and also the endovascular guys will tell you that oftentimes Mercy in their hand will take 3 or 4 passes if they're going to be successful, meaning the first generation device, while with the stent reader, they're getting much more, or a much higher rate of success with recanalization in the first pass with the stent reader.
And our interventionists, as I mentioned, use what they call the Solumbra technique. So they open up the vessel, but they're using the penumbra to suck out any potential clots that might go elsewhere. So they're kind of using two retrievers or techniques in one.
So is the type of recanalization, actual recanalization captured to be faster? Looking at the previous trials.
I don't think that, the time, I don't know those data in detail. There's going to be a pooled analysis of all these trials presented at ISC, so I think we'll see all of those data.
Kyra, one of the, in that, by the way, that was a terrific talk. That was absolutely wonderful. There's so much practical information in that for those of us who are very occasional stroke doctors. So thanks for that very important talk. I'm amazed at the difference between I can never remember the names, the SWIFT, the fancy imaging studies versus the other ones. And it could well be that the outcome was preordained. They were much more selective, picked the cherries, the ripest fruit from the tree, and got a better outcome. But it seems to me that that's just a guess on my part and on anyone's part. It really would be interesting to look at the full range of patients that were treated in the other studies and use that fancy imaging technique and find out whether or not our presumption is correct.
I suspect those studies are coming. Yeah.
Sure. Is there any use for intraarterial TPA with or without a stem retriever, or is that totally gone by the wayside?
I think Chris's question is, has the use of intraarterial TPA gone by the wayside? I think still on occasion, if a clot goes down a distal vessel, the interventionist will use it, but there's no data in support of that. So it's, I think, just kind of an interventionist, kind of preference. Yeah, and I think, in fact, I didn't include all of the updates on the new guidelines, but I think they mention in particular that there aren't data to support intraarterial TPA at this point.
How far out can they get these retrievers now?
Well, so I know they can get into M2, but the guidelines suggest that really it's ICA M1, but they have gone to M2, they have gone to ACA, they have gone to P1.
P1 too.
Can I thank you for explaining those various cryptic initials to us? That was good, Kyra. Chads and aspects and blah, blah, blah.
Sure.
Very helpful. Thanks, Kyra.